just wanted to talk to you about healthcare transition and a little bit about my personal experiences. And Sharon, who's been my partner in many of these endeavors, I'm really sorry she moved to Indiana. And I'll start by talking about a young lady I saw at the Mind Institute. We'll call her DP. She has a complex genetic condition. And what really struck me about her was that she was such a sweet, charming girl, but she was severely intellectually disabled, functioning at a preschool level. Her parents were, relatively low income. Their primary language was Spanish. She had multiple subspecialists, heart specialist and pediatric eye doctor, orthopedics physician, several specialists involved in her care. She was in a special education program at her local high school, and I asked the family about what kind of vocational skills training she was getting, and they were not really sure. She said the last job she had was picking up trash from the school grounds. And I asked the mother, what worries do you have, what concerns do you have? And her biggest concern was who's going to take care of her in the future. She has so many subspecialty appointments. She has a condition which very few pediatricians, let alone adult doctors, are familiar with. And she had no information about how to go about the healthcare transition process, about reproductive rights, insurance issues. She didn't know what guardianship meant. She didn't know whether she could ever work or live independently. She was quite overwhelmed when we asked her all these questions. And we'll come back to how we might address some of these questions. How would you plan for her transition? How would the family find an adult provider? What about adult subspecialists? What other issues should we be considering in terms of her future care and how we would address these issues? What are the community resources available? What options do the parents have if they're too old or too sick to take care of her? And between Sharon and I, we'll try and address some of these answers, and I'd actually like to come back to these questions in the interactive session, which I hope you'll stay for, and maybe we can answer some of these questions as a team with input from all of you. So the learning objectives today are to describe the healthcare transition agenda of medical providers and their organizations. So I'll be talking from a physician's perspective, but we'll also have family perspectives in the second half. Kathy Mititka, who's here, is going to talk to us about some of the experiences she has had with her daughter and understand the best practice guidelines. Recently in 2001, there was a report published in Pediatrics which gives best practice guidelines for healthcare transition, and to also identify practical ways we can use these guidelines. What is healthcare transition? So basically it's lifelong functioning and well-being of all youth. And we want high-quality, developmentally appropriate healthcare services which are available in an uninterrupted manner, which means it's not just a drift-off or very abrupt, like what happens with many families. The day you turn 18, you're suddenly transferred to adult care. We want a kind of seamless but well-planned execution of transfer of healthcare. And the Maternal and Child Health Bureau defines successful healthcare as being seamless, effective, and comprehensive for all youth and families. So this is not just for children with special healthcare needs, but for all youth. And why is this important? We all know there's a whole slew of youth with special healthcare needs who are transferring into adulthood with earlier diagnosis, better healthcare, better healthcare systems. You know that there's hundreds of children every year transferring to adult healthcare, which wasn't the case a few decades ago. And they say about 13% of children in the United States have special healthcare needs, and they actually take up more than 80% of all the healthcare expenditure dollars. So it's a very big issue in terms of not just patient population, but also healthcare expenditures. And if they don't have seamless transition to adult healthcare, they lose insurance coverage. They don't have a medical home they can go to. They have more hospitalizations. They have more fragmented care. These are the folks you often see in the emergency room because they don't have a doctor they can go to. So there's many issues involved in this process. But most importantly, young adults need to be at the center of their own healthcare. So those who are cognitively able to do so, they really need to be advocates for their own healthcare, and they and their caregivers need to know what it means to be an informed decision maker. So the transition movement really started as late as 2002 when the American Academy of Pediatrics and the American Academy of Family Physicians and the American College of Physicians issued a consensus statement regarding this. And it's also one of the 6 performance priorities for the National Maternal and Child Health Policy. The Affordable Care Act defines transition as an essential health service. So there are many organizations, many reports which have come out saying how important this issue is. Every 5 years, there's a national survey of children with special healthcare needs that's conducted across the population. It's a phone survey, and the last survey, which was 2009 to 2010, the results of which were just published recently, show that only 40% received transition-related services. And the figures are even lower in California. They're just 37.4%. And there's also a big disproportion. Only 22% of Latino youth received any kind of transition-related services in the healthcare system, as opposed to 50% of Caucasian youth. So there's also a lot of minority discrepancy. So who did not meet transition outcome, which means that they never had a discussion with their provider about transition. They were never asked questions about insurance changes when they reach adulthood. Typically, it was boys, minorities, youth with no medical home, those who had a developmental, emotional, or behavioral condition, which is relevant to us in this audience, those with no insurance or public health insurance, and people who were 100 to 400% below the federal poverty level. So these are the ones who typically fall through the cracks. And these are the kinds of patients I'm most interested in serving, because I think they're really the ones who cannot advocate for themselves. And Sharon and I share this passion for helping such families. Why is it so hard to do any kind of transition-related services? I've kind of highlighted the ones which are most problematic, and we see this firsthand. There are very few adult providers who are well-versed in dealing with these youth. There's also fragmentation of adult primary and specialty care. The other big barrier we see is insurance. When Medi-Cal runs out or CCS runs out, people have no idea of how to navigate the system. There's also a big anxiety on part of pediatricians and families to let go, because they have this bond. They're used to a warm and fuzzy pediatric office, and they just don't want to transfer to the adult healthcare model. And we are all familiar with that, because people form relationships with their pediatrician over several years, and pediatric care is essentially very family-focused as opposed to adult healthcare, which is very individualized. The other big reason we see, this is something that I have experienced firsthand when I was in pediatric practice, is lack of time. With all the 15-minute appointments, which is what most well-child care is, it's really hard to find time to discuss this huge issue of transition, which requires several visits and long-term planning. I'm also interested in research to identify best practices and more advocacy ventures in this area. Other reasons for why transition doesn't work well is many youth are not used to discussing their own health or advocating for themselves. We pediatricians often ask young adolescents about things like alcohol use and sexual activity, but they forget to ask them, what are your medications? What is your diagnosis? Simple questions like that, because the moms always answer for them, moms or dads. Family physicians have a slightly easier time because they're used to taking care of both youth and adults, but they need to transfer to the adult model of care too, and they also need to transfer their patients to adult subspecialists. They also need to discuss things like insurance changes and independent living needs, etc. Again, we'd already talked about the challenges which internists might face, and one of the reasons which I didn't talk about is the consent for treatment and the guardianship forms that are required for those who reach 18. And this is something which Sharon will talk more about later. I wanted to mention a few words about what a patient-centered medical home is. This is really becoming standard of care in both pediatric and adult practices, and many healthcare organizations as well as insurances are recognizing how important this is for providing high-quality care. And providing transition care and support has become one of these standards, which I think in the future will be really important. A patient-centered medical home provides, by definition, accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective care. And part of patient-centered medical home requirements is to have a registry of children with special healthcare needs. So those of you in the medical field, I think this is really, really important that your pediatrician's office has this kind of registry, and that they also provide chronic care management plans and co-management with subspecialties. So like I mentioned before, in 2001, a clinical report was brought out by the journal Pediatrics, which talks about supporting healthcare transition from adolescence to adulthood in the medical home. And it was developed by an expert authoring group. And it was also reviewed by a large and diverse constituency, including community members, stakeholders, families, and young adults who've been through the transition process. And it talks about 4 main healthcare agenda items, that is best practice guidelines for pediatric providers and for adult providers, financing, education, and research in this area. So it's a really nice article, which those of you who are interested in this could use as a resource. So this report actually has a sort of a toolkit with an algorithmic structure which provides framework on how to go about the transition process, and it also provides, it's for both primary and specialty care, and it starts talking about beginning the transition process as early as the 12-year checkup, not waiting till you're in your late teens or 18 years of age. And it extends through to the transfer to adult healthcare as well as adult specialists. Part of getting ready for transition is participation of the medical home team, which means the pediatric provider's office, the patients, the families, other caregivers, and also preparing the receiving adult medical home. And we'll talk about the 6 steps, 6 core elements of healthcare transition. This was developed by Got Transition, and the director of the center is also the lead author of that clinical report. It's a federally funded National Healthcare Transition Center based in New Hampshire, but it's developed this core package of healthcare transition elements. And this is a really good website to, when I give you the list of resources, this is like the go-to website for any kind of transition-related services. It has resources for families, resources for providers, all the research in this area. It's an excellent website. So the 6 core elements which I wanted to talk about. The first one is having a healthcare transition policy, which means an explicit written policy in the office which talks about when the transition might occur. It could vary from practice to practice or office to office. In some healthcare systems, I know, if I'm not wrong, in Kaiser, when you turn 18, you automatically transition to the adult healthcare world. In other systems, like the system I come from, in UC Davis, it really depends on the preference of the pediatric provider and the patients and the family as to when they transition. I know some pediatricians who have patients in their late 20s or even early 30s. So there has to, but it should be written in as a policy as to when this might occur. It could be with mutual consent of family and patient. The other thing is to have a registry of all the youth in the transition age and identify these youth and actually track their progress over time. The next step is transition preparation, which means start talking about what kind of needs they might have when they reach adulthood, what are the, how ready is the youth and the family for transition, just talking about planning for the future. And the next step is, of course, actual transition planning, that is finding out what adult providers they might need, what are the changes they might need in terms of insurance, what are the changes they might need, if any, for guardianship or conservatorship, There's actually planning readiness toolkits. Again, it's available on the Got Transition website, so you can refer to that. And the next step is actually transitioning and transferring care. And I think this, a key element of this is to have an active communication between the pediatric provider and the adult provider, and not just some paperwork transferred over. I think having a portable medical summary is very critical, and I'm really working in UC Davis to make sure every patient with any special healthcare needs has a portable medical summary that can be transferred over to the medical health, to the adult health provider. Also having an emergency care plan, making sure your insurance is sorted out before you transition so you don't fall through the cracks and land up in the emergency room. And the last step is when you actually transfer care and have a new medical home. So this process, as you can imagine, doesn't happen in one visit. It takes several years, which is why I urge you, even if your pediatrician is not talking about transition-related services, I really request any medical provider, allied health professional or families to be the advocates for talking about this with the pediatrician so that this care starts early and not last minute. There's been a lot of research being done in this area. The Got Transition website actually has 4 learning collaboratives in the areas that are on the slide. And they're piloting primary care quality approaches to healthcare transition, and they're using healthcare transition index to track progress. And I'll show you some slides in the next few minutes about how well that's been working in just a few months. Just using the toolkit and following the steps outlined in the clinical report have made dramatic changes in the quality of healthcare. At UC Davis, Dr. Hansen already mentioned that we started a transition care coordination clinic, which is staffed by a physician, a social worker, a community transition specialist, and a nurse coordinator who's really helping families go through the transition process, and the appointments are extended appointments lasting an hour. So we all meet with the families and really go through the transition process, and we've tried to take on the most complex patients. Again, we've faced many, many challenges on the way. Number one being insurance and lack of adult providers who are willing to take on these patients. It's been a huge challenge because of all these issues. I'm also trying to teach internal medicine residents on how to take care of these patients, which is my next area of research. So this graph actually shows you how well just using a checklist and the toolkit has worked for transitioning. So the scores at baseline are in blue, and as you move up on this transition index ladder, which means better transition healthcare services, in essence, you can see how dramatically from February to October in just a few months, how impressive the results are. And the same thing happened in adult practices as well. I won't go into the details, you can refer to the source, but it just shows you that just having systems of care in place without any, this didn't require any fancy equipment or anything, it just required systematic planning. This is a question I get asked a lot by families. How do I find an adult doctor? And I just wanted to give you, these are not quote unquote evidence-based, these are just my personal experiences and just my experience as a physician. I think for some families, the caregivers can probably choose their own doctor. Their parents or the guardians can have their own doctor be their child's doctor because they already have a relationship with the family and they know their doctor. Med-Peds doctors or family practice doctors who have experience with both youth and adults are also good resources. Other thing is to ask friends or family for a doctor who has good communication skills, who is interested in learning, and who's also in your area and your insurance network. So what you're looking for is not somebody who's an expert in, say, osteogenesis imperfecta, but you're looking for somebody who's invested in learning about it and, learning from the pediatrician, learning from the literature, learning from families, and who also has good communication skills, because I think that's really critical. Your pediatrician can also be a good resource, and the least preferred is to just get a list from your insurance panel of all the doctors in your neighborhood and just shop around, so you can actually arrange for a social visit as opposed to a medical visit and just meet the doctors who might be a good fit for you.
So here's just kind of a statement for you all, just real quick. We raise our kids, and we do a lot of things for them, and we make choices for them and important decisions. During this time of transition from childhood to adulthood, we're given an opportunity to move from doing for our children to one where we can make decisions and plans with our young adults. And when we accept that our children will not be children forever, that all children, including those with special needs, become of adult age, we want to find ways to help them explore a life that is their own, with preferences, choices, and ways for them to express themselves. We teach our children about advocacy skills, informed decision-making, natural consequences, and walk this path with them rather than for them. And on the other hand, we do not just send our kids out into the world unsupported. Rather, we take this time to educate ourselves to the possibilities, services, and community resources available to our young people in order to aid them to find a purposeful and meaningful life. And I always preface this conversation of transition with that, because I think we work so hard to take good care of our kids. And now that they are growing and that they're going to become young adults, we really want to help them to focus on ways for them to be a part of this process. It's their life, it's their journey. Conservatorship is one of those areas that we could talk for hours about. It's a really important process that needs to start way before, well, my kid's 18, 19 years old. It needs to be thought about throughout the life of the young person, and thinking about advocacy, shared decision-making, how we help make plans for people, competency, capacity, who's going to be able to make good choices for themselves, and who's going to need the support of others to help make that happen. And then finally, conservatorship, which, as it says, is a legal process that gives one person the power over another with regard to decision making. And that is a very serious process. It's a legal process. In the state of California, we recognize 3 different types of conservatorship. One is the general, which is where someone is really deemed incapable of making good choices for themselves all the way around. The other would be a limited conservatorship, which oftentimes has to do with medical and health care, or certainly fiscal issues, in order to help make sure that people are going to be able to be in the community successfully with income and benefits and all of that. And then the third one, which is for folks who have serious mental health issues that in fact need to be institutionalized for short period or long periods of time. And so again, you can get into lots of discussion around that, and I think what's most important for people to understand is you need to start this planning process early. You need to be thinking about your youth and ways that they can learn about themselves, their health conditions, their disability, their need for independence, their likes and dislikes, and then start thinking about decision making. Who's able to make those decisions? How do you do that in a shared way? There are a lot of families who perhaps sign medical consents with individuals, young adults, who don't go the conservatorship route, but they go the shared decision-making route, which can, where the young person is fully cooperative and says, yeah, you know, I want my mom or my dad or my guardian to help me in this decision-making process. And that can be sufficient oftentimes for treatment. And consent for treatment, but at the same time, if things are more complicated or other circumstances, we do encourage people to seek legal assistance. You cannot get a conservatorship in the state of California without going through legal support. And there are lots of resources available. We can certainly delve into this more and talk about more of this in our follow-up session. So insurances and barriers, I don't know how many of you were able to be here for the talk on the Affordable Care Act and the health care and all of that this morning. Good number of you, good. Yeah, you know, it was very informative for me. This is an ongoing process that's changing so dramatically. I think if anything that we really need to understand from a family perspective and certainly from a provider perspective is that people can stay on, our kids can stay on our employer-paid or parent-paid insurance plans until the age of 26, which is great. There is no more pre-existing condition denial, which is amazing. And there's no annual or lifetime limits, which I think is really extraordinary. Medicaid and Medi-Cal expansion, there's 70 programs of Medi-Cal, which again is California's Medicaid program. So there's lots of opportunities for people to qualify for a variety of different programs, but it is very convoluted in terms of its process and its understanding. We have a lot of young people now, when they hit 18, they may have been eligible for Medi-Cal or CCS until they're 21, but in fact, when those age caps are coming up, they're finding that they're now without insurance, without a whole lot of understanding and information that they have to now go back and reapply. Just because they're cut and kicked off of Medi-Cal at 18 does not mean, in fact, that they don't go and reapply as an adult on their own and find a program that they can get into. And again, with the Affordable Care Act, there'll be some more options available to them too. It's a very challenging process. It's not one that you can start 2 months before the person turns 18. And it's not one as a medical provider that we should be talking about after you get the denial of Medi-Cal because your last appointment wasn't funded because the person actually was kicked out of the insurance. So education and transition, it starts at 16 typically with California Department of Education. Federal law states 14. I can't stress this enough for families who are interested in how this is all connected truly to healthcare. Again, it's about understanding how to make good informed decisions. It's about advancing education, which leads to employment, which helps people to get benefits such as healthcare, and certainly income to help pay for those things. We really want to be looking at our young people as an opportunity during this time, during these teen years, during this youth window, if you will, to really be thinking about ways for them to incorporate healthcare issues if they have special healthcare needs into their IEP. It could advance opportunities for them to pursue avenues around assistive technology, support while they're in school, ongoing learning, sexual literacy, opportunities for people to be having some advanced learning and alternative learning that goes on while they're in school. And I encourage you, this website at the bottom, the National Secondary Transition Tech Assist Center, is a great option for people. Vocational planning and training, you know, one of the saddest things is to have somebody go all the way through, even to their 22nd year in public education, and not have a day of real relevant vocational training. We need to make sure that we're empowering families and everyone in that person's healthcare team to be sure that they're getting opportunities, again, for job training, for community inclusion, for activities that are outside. Those are all things that promote wellness, and you can string it all back to good healthcare transition. Community integration, understanding, you know, where are people going to live? I have, you know, my standard call that I get on a regular basis and have for years. Bernice is 82 years old, and her son Bobby is, you know, 56. He's lived with her his whole entire life, and she's calling now because she's at the end of her life, and she wants to know what's going to happen for him. He's been living in the same room he was raised in, and he goes to the same day wasting program that he's been at for 40 years. And it's a shame, it's sad, but there's lots of people out there still kind of wandering through that. Our youth today really do expect a lot more, and we want them to have more. So be talking about community integration and how that falls into healthcare and wellness. Sexual literacy is a really important one, and we oftentimes focus a lot on this with regard to the young women that we encounter, but we need to remember that men and women are all sexual creatures, and that we need to pursue this education for all of our youth, not just our youth that don't have intellectual disabilities or that don't have special health care needs or that we wouldn't want to have and engage in this conversation, which is a real plug too, I think, for oftentimes helping pediatricians move their young people, their young adults onto adult medicine. I think adult providers are often more comfortable having conversations that maybe most of our pediatricians aren't comfortable having. And I think more important than that, these are adult issues, and we want them to have all of the access and the support. Planned Parenthood is still a wonderful resource for families and for young people who need sexual literacy, education, things like that. And then just with regard to reproductive issues, we have a lot of families that don't have health insurance and good health insurance, and we just want them to know that they can still get lots of good support.
So I'll just end with a few take-home pearls for all of you, and I see most of you are family members. So number one message is start planning early. Don't wait till the late teens. So start planning early. Start teaching self-advocacy skills to those who can learn them. When you're looking for an adult provider, talk to them, meet them. Ask your pediatrician for a portable medical summary if it's not offered to you. Say, I just need like 2 pages, not reams and reams of electronic health records, which no adult provider or any provider is going to read. So you just want this 2-page summary at the most. Have an office transition policy for those of you who are providers and involve staff, as well as families who might be interested in this area. And again, for providers, keep a registry and track their progress. And for youth and families who have disabilities, discuss things like insurance, look for community supports, educational resources, vocational skills training, decision making. The regional center has classes on sexual literacy and safety, which you can access. Talk about mental health issues. Many of our young adults have depression because they're different from all their peers. So talk about these things with your doctor, seek out resources, and we'll be, in your flash drives, you should have a number of resources, and there's several in the slides too. And for physicians, I would strongly urge you to code for the time you're spending with these patients, because I know financial barriers and lack of time are a huge issue. So I've just included that for those who need it. And this is my message: all youth need education, guidance, and planning to assume greater responsibility for their own health and well-being into adulthood, and I hope that will happen in the years to come. And these are a list of resources which you can access. So several of these have excellent transition checklists you can go through. So as families, you can actually say, did I do this? Did I do this in order to prepare for transition? So many of these, especially the Got Transition website, for the first 3 are really good resources. And I wanted to say a special thanks to Dr. Hansen, all the UCED staff, to Sharon, our own families, and all the wonderful provider staff, patients, and families at the Mind Institute.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.